Thank you. I'd like to thank the organizers for the opportunity to speak here at this really productive workshop. Yes, so today I'm going to talk about basically a comparison of universal access and universal test and treat strategies in South Africa. And, oh, yes, sorry. Yes, if you didn't hear that, yes, today I'm going to compare universal access to treatment and universal test and treat strategies for South Africa. Basically, I have two objectives in the talk, and the first objective is to look at, is elimination possible in South Africa? Namely, what would be the threshold of CD4 level at treatment initiation and testing frequency that would be necessary based on other aspects of epidemiology. And secondly, the work is a comparison of test and treat and universal access strategies in terms of transmission, resistance, the numbers of individuals that would actually be on treatment over time, as well as the treatment costs, so the main structure of the model is based on the Granic et al. Model that I think most of you are familiar with, that was in Lancet in 2009. The structure, there are differences, some important differences in the structure as well as in the parameterization of the model. As far as structure, we've included primary infection as well as the dynamics of acquired and transmitted resistance. In terms of parameterization, the salient features are we have included a heterogeneity in treatment response, and this includes looking at the differences in terms of the proportion of individuals who are virally suppressed, as well as the degree of viral suppression among the partially suppressed individuals. Lastly, a very important feature is we've looked at new data on treatment survival times and incorporated this into the model based on drug regimens. So this is just a review of the Granic et al. Model, and as you see, it's a 4-class model with 4 infected stages and 4 treatment stages. Now, in this model, the infectivity in each stage was identical. As well, an individual would spend 2.25 years in each stage. Our model is somewhat different. We have a 3-stage model, and here we've included primary infection, chronic infection, and symptomatic infection. So here you'll notice beta 1 represents the infectivity during primary infection, and it's going to be higher than beta 3, the symptomatic infection, which is again higher than the infectivity in chronic infection. Now, for our stages, we have a primary infection. For our base model, we have a time of 2 months in primary infection, 7 years in the chronic stage, and 4 years in the symptomatic stage. Okay. So, right. So what are the major differences between the models? And one important part of the parameterization. Okay. Thank you. Sorry about that. Okay, so one important part of the parameterization is the additional life years gained between the two models. So just to compare, in the Granic et al. Model, if treatment were initiated at 350, at a CD4 count of 350, there would be 6 additional life years gained due to treatment. In our model, we've modeled this actually as having several decades of life years gained due to treatment. If treatment were initiated at 700, in that model, an additional 5 years would be gained on top of that 6, and we've kept that assumption since there's very little data on treatment above that time, above that CD4 level. So what I'd like to show now, these are some results about elimination. And what we've modeled here, you'll notice I have HPTN 052 and 96%. What we modeled is a reduction in infectivity due to treatment. So this includes viral suppression and the level of viral suppression, so a 96% reduction in infectivity. And what you see on the vertical axis is the average time between tests in the population, and on the horizontal axis, you see the CD4 level at treatment initiation. The colors represent the reproduction control number, and you're probably familiar with the reproduction number of a disease. Well, the reproduction control number is simply that number when an intervention such as treatment is in place. And the important part of this is when that number goes below 1, theoretically, we have elimination of the disease. Above it, we do not have elimination. And what you'll see here is that for this 96% reduction, if that were maintained, very near, the arrow points to roughly 350, or does point to 350, we would be very close to elimination if we had a testing frequency of essentially half a year, twice a year. Now, what's also interesting is if testing frequency were above 4 years, elimination wouldn't be possible at all. Now, these results change a lot when we look at different reductions in infectivity due to treatment. So this is looking at an 85% reduction in infectivity, and what you see is that elimination would actually be impossible even if testing were very frequent, if initiation weren't at about 700, a CD4 level of 700. And again, if testing were less than once a year, or less than basically 3 times in 2 years, elimination would not be possible. So what we see here is that test and treat would lead to elimination in this, but it requires a high testing frequency. And of course, that is where the second arrow is pointing to where to 350. So we see we're very far away from elimination there. So now I want to move to the comparison of the dynamics of a test and treat scenario versus test and treat versus the universal access to treatment. Now what we see here is the incidence reduction. So we have wild type and drug resistance. You notice that the transmitted drug resistance is quite low, and we've made very, very conservative assumptions on what transmitted drug resistance would be. But the important part here, again, this is assuming a 90% reduction in infectivity due to treatment and acquired drug resistance of 3% per year in the population, in the treated population. And what you see is a dramatic reduction in incidence in both the universal access to treatment strategy as well as the test and treat strategy, with the test and treat strategy essentially achieving elimination after 40 years. Again, looking at the infections prevented for this, in millions, again over time, you see both the test and treat strategies and the universal access strategies prevent a large number of infections, very substantial. However, of course, test and treat prevents considerably more. Now, moving on to the numbers on treatment, and what you see here again, we're looking at the numbers. We have numbers of drug resistant on treatment in red, and the test and treat wild type in blue, universal access in black. And what you see is the peak numbers in the test and treat strategy are much higher than the universal access to treatment strategy. As well, drug resistance increases substantially over the 40-year period in both the test and treat strategy and the universal access to treatment strategy. As well, you'll notice after 40 years that there are millions of individuals on treatment. And this is a key point. And this is the point that elimination really isn't everything. And it's obviously extremely important, but if you look at incidence versus numbers on treatment, after 10 years, we've reduced incidence to 0.4%, but we still have 4.5 million individuals on treatment. Likewise, after 40 years, we've reduced to 0.2%, but we have 4 million individuals who are in need of treatment and who are on treatment. So the important part here is their viral suppression would have to be maintained, and they'd have to continue treatment. So this is something that it's important to look at elimination, but it's also important to realize what we have to maintain. Moving on to costs, What we've assumed here for costs is, again, we have annual testing. We've discounted costs 3.5% per year. We've assumed, based on previous studies, a first-line treatment cost of $751 and second-line costs, as you see. And again, acquired drug resistance is 3% per year. So this is included in the cost. And you see that over a short time period, the test and treat strategy is far more expensive, much higher peak costs than universal access. Now, it is important to note that the test and treat strategy will become cheaper than the universal access strategy, but it takes quite a while, and we see this occurs at essentially 25 years. Now, well, what does this mean in terms of cumulative cost? Because this is something also that we want to look at. Well, despite the fact there is this crossover between test and treat and universal access, the cumulative costs of test and treat are still much higher over a 40-year period than universal access, with costs based on those drug costs that we've, treatment costs that we've shown, essentially $85 billion. So despite the fact there is this crossover, the test and treat is always more expensive. So to summarize, the test and treat strategy that we've shown, it achieves elimination, but in fact, universal access still is very close and achieves substantial reductions in incidence, like we've shown. Elimination, as I pointed out, is not everything, because even after elimination, millions of individuals still need treatment and need to maintain viral suppression. The cost of test and treat, as I've shown, will be greater than universal access, and that's in contrast to what some other models have shown. So specifically some of the WHO models, this is opposite. So what is the reason for this? Well, the reason is the inclusion of more realistic survival times, and as well the inclusion of drug resistance. So in closing, I'd just like to say that it's essential that we really look at how to model costs more effectively, and that's something I'd really be interested in talking with health economists or other individuals to try to work on. Thank you.